Hi, everyone. I'm Rachel DeGrand with Hausman Group. Thank you for joining us for today's webinar, Regulatory and Legislative Updates and Compliance, presented by Casey Ripstein. If you have a question during the webinar, feel free to type it into the questions feature and we'll address it over at the end of the webinar as time allows. After the webinar is over, there will be a short survey we're hoping you can fill out for us. This webinar has been certified for continuing education credits by SHRM and HRCI. Details on those credits will be provided to you at the end. After the webinar is over, there will be a short survey we're hoping you can fill out for us. This webinar has been certified for continuing education credits by SHRM and HRCI. Details on those credits will be provided to you at the end of the webinar. Also, this webinar is being recorded and will be available for review on the webinar archives of our website. You will receive a follow-up email with a link to the recording and the presentation slides. I'd now like to introduce you to our presenter for today's webinar, Casey Ripstein, with our compliance partner, Benefits Compliance Solutions. Casey has over 20 years of experience in employee benefits, with 15 of those years focused on building a dedicated compliance practice for a large national brokerage. In this role, his leadership was central to scaling brokerage operations during periods of massive regulatory change. His knowledge of health and welfare compliance is among the best in the nation, but his greatest skill set is a knack for making difficult topics easy to understand and apply. And that's why he's here with us today. Welcome, Casey.
Thank you. Thanks for having me. Thanks for joining us, everyone. What we'd like to do today is just kind of review some of the things that are probably top of mind for most employers out there at this point in the year. We'll start off with a little bit of a discussion about ACA reporting because you're probably in the thick of that right now and trying to wrap it up. We want to make sure no employer is missed. So some of that does hinge on whether you're an applicable large employer. So we definitely want to revisit that topic for a moment, make sure our counting is right and we know what we're subject to when it comes to ACA reporting. We had a Mental Health Parity and Addiction Equity Act final rule towards the end of last year with a lot of requirements going into effect in 2025. So we do feel like we need to spend a few moments reviewing the rules that we've had, what's changing for 2025, and where we go from here. We had a proposed cyber update to HIPAA security rule. That's probably under a little bit of a freeze, maybe a pause right now. But as you know, cyber breaches are on the rise. They are never ending. They are increasing in scope and magnitude. So a discussion seems warranted, even if the proposed rule significantly changes or just goes away. It's still worth having a cybersecurity discussion. So we'll keep that one brief, but get into some important points to cover. RxDC annual reporting is coming up June 1. So we do want to talk about that ahead of June 1 in order for our carrier and TPA partners to help us with that. They need some information from us as employers in advance of that deadline. And that means they're going to be reaching out in the next couple of weeks. So we want to talk about what they're going to be looking for from us. And then, of course, we have a new Congress, new administration. Need to spend a moment just talking about what are things looking like 1 month in. So with that, let's dive into some Affordable Care Act discussion. We'll start with the reporting. And just as a level set, for an applicable large employer, they're in the green box on the right. These are the employers with 50 or more full-time and equivalents. They do have to do those 1095-C forms and a 1094-C cover sheet. And there is no assistance from an insurance company or a third-party administrator helping you with your medical plan. They don't really do anything to help with these C forms. So we've had this requirement for quite a long time, since 2015. So it shouldn't be new, but applicable large employers do need to complete C forms. And the general rule is a 1095-C is owed to every employee that was full-time in 2024. There's some small exceptions to that, but for the most part, everyone that was full-time in 2024 needs to be evaluated and probably given a form. There are 3 parts of the 1095-C. Part 1 just has the employer and employee info. Part 2 is code driven. So if you're familiar with the W-2, now has all those codes to indicate in box 12 what represents what. This is similar. In lines 14, 15, and 16 of Part 2, we report our offers using codes and what people did with our offer using codes down in line 16. Part 3 is a section that reports who in the family was enrolled in our coverage for any months that our coverage was level funded, self-funded, or an ICRA. So if our coverage is fully insured all year, we are going to skip Part 3. We're not going to populate it at all. But if there are any months of 2024 where our coverage was level funded, self-funded, or an individual coverage HRA, we're going to report the employees and family members that enrolled in that plan and the months they were enrolled in that plan. So that's what Part 3 accomplishes. We need to provide this 1095-C to individuals that we're generating a form for by March 3rd. So that's our deadline. And we're going to talk in a minute on our next slide about some possible relief related to that. And then we have to give all of the 1095-Cs that we generate, along with the 1094-C cover sheet, to the IRS electronically by the end of March. So statements to individuals at the beginning of March, all the electronic filing to the IRS at the end of March. That's actually sent to them via an XML file. So they don't actually get PDFs of 1094-C and each 1095-C. They get an XML file that translates all the information on those forms into one electronic file. So it's really important for an employer to go through all the reporting that's being generated for you for accuracy, including this XML file, and making sure it has all the required information, it's accurate, it's up to date, doesn't have extra things in there that don't belong in there. We want to make sure it's accurate and complete. For our non-ALEs, these are the employers who did not have 50 or more full-time and equivalents over calendar year 2023. So they were not an ALE in 2024. If you are fully insured for all 12 months of 2024, there's no ACA reporting for you to do. However, if you had any months of 2024 where coverage was level funded, self-funded, or an ICRA, we do want to report the employees and family members that enrolled in that coverage and the months that they had it. So we will only provide these forms to people actually enrolled, not to everybody we offered a level funded, self-funded, or ICRA plan to, just those who enroll. This likewise has a March 3rd individual statement delivery date to people and a March 31 delivery date to the IRS. It is also required to be electronically filed. So we'll have an XML file to look through, verify everything for accuracy, and make sure that deadline is met. We also have a comment down at the bottom that some states have an individual mandate, health coverage mandate, and require reporting. So to the extent your e-filing vendor helps you with these B forms or C forms, whichever one you're doing, they will probably likely help you with these state filings too. The exception might be Massachusetts, which has its own form. That e-filing vendor might or might not be able to help you with that part. So that part you might have to fill in a gap on. But for the most part, I think a lot of these e-filing vendors are helping with the other states. We have some relief, though, with trying to provide statements to individuals. That's the 1095-B or the 1095-C. We have some relief to where if we will provide a notice on our public website with instructions of how to request a copy of that form, then we only have to give it to those who reach out and request a copy. So for employers that want to take advantage of that, whether you're an ALE or a non-ALE, you can take advantage of this. We need to have the required language that you see on the right side here on our public website. And we want to have that out there by March 3rd, since that's the date people can start asking for their forms. And as long as we have the right language, we can limit providing the notice, the 1095-B or 1095-C, to just those who request. So that's really good. And we can provide that electronically to anyone who's granted electronic consent. Some other relief that ALEs recently got from Congress is that if a penalty letter arrives someday from the IRS, these applicable large employers now have 90 days to respond. We used to have 30 days, and when the letter arrived, 2 or 3 weeks may have gone by the time it arrived in snail mail. and made its way through the channels to the right person's desk. So we were often having to call and ask for a 30-day extension to give us 60 days. Well, now you have 90 days to begin with. And if you call and ask for extension, you'll get an additional 30. So that's really good news. The other good news is the IRS only has 6 years from now on to send such notices. This is the 226J penalty notice for an applicable large employer. They would have 6 years from the date your 1094C and 1095C filing is due. Or if you end up filing those forms late, they'll have 6 years from the date you actually file if you file late. So that's really good news because now employers can just keep records on file for 6 years and know that after the statute of limitations expires, those records can be discarded and we don't need to keep records forever. Another update that we got in mid-January is an updated federal poverty level. So you can see the numbers here of where federal poverty level went. Our calendar year plans can't take advantage of that because it comes out after the calendar year has begun. But our non-calendar year plans can use the new FPL for the new year to calculate affordability. For an applicable large employer, affordability is based on the lowest cost single plan providing minimum value. So if you offer 2 or 3 plans, we're only concerned with the lowest cost plan that provides minimum value. And we only have to pay attention to the single tier, not worried about affordability on any tier that covers dependents. So when we're thinking about how much we charge employees for that lowest cost single plan, if we can be FPL affordable and charge them no more than the dollar amount that represents your plan year, being FPL affordable can give us some advantages. It actually blocks employees from applying for a tax credit in the public marketplace. So those 226J penalty letters that we just talked about are only generated when someone that's full-time goes to the marketplace and qualifies for a tax credit to buy coverage there. If we are FPL affordable and can block employees from even applying for such a tax credit in the first place, then we know they can never trigger such a penalty to us because they never qualify for a subsidy in the first place. And some other relief that can be available if the employer is FPL affordable all calendar year and spouses are eligible even if they have access to coverage through their own work, and children are eligible to the end of the month they turn 26, the IRS calls this a qualifying offer. And if we check on our 1094C cover sheet that we want to take advantage of the qualifying offer method, then each 1095C that has a qualifying offer to report can code that as a 1A in line 14 and leave lines 15 and 16 blank. What this means for an employer, why this is an advantage to the employer, is that's 2/3 less data to audit later. When you're reviewing all the output that's generated for your ACA forms and your XML file too, you will have basically one row of data to go through for most people, row 14. If lines 15 and 16 are blank, you have much less data to audit. So that can save you significant time, especially as the number of forms you have generated increase. Now, all of that is predicated whether you're doing C forms or B forms and need to pay attention to affordability based on whether you're an applicable large employer or not. And sometimes you're well over 50 and don't need to worry about it. You know you're an applicable large employer. You don't need to do any kind of special calculation. You're in good shape. Some employers are a little bit fuzzy on, am I an applicable large employer or not? So to that extent, we provide a calculator that can help you do the math. It is an average over the prior calendar year to determine if you had 50 or more full-time and equivalents that makes you an applicable large employer the following calendar year. There's some specific counting rules that go into that, so our calculator builds in a description of each role and has special fields to enter what's required to do the math right. So this can be a really helpful tool And if you determine you're not an applicable large employer, this calculator is great to keep on file for that 6-year statute of limitations we talked about, where maybe the IRS sees, wow, you have a lot of W-2s filed each year. How come I'm not seeing 1095-Cs from you each year? You would have this calculator on file to demonstrate you've done all the math and you've done it correctly in accordance with the law and proven each and every year not an applicable large employer. So this calculator can be very good to keep on file for 6 years. And one thing in particular, in order to do that calculator correctly, is you do need to understand if you're under common ownership or control with some other employers out there, some other EINs, to where maybe there's some common ownership or common control. If that ownership or control is at a high enough level to put these employers in a controlled group or affiliated service group under the tax code, the counts have to be combined. So the employment counts at each entity have to get combined when you're populating the calendar. So just know that going in order to do the calculator right, it has a lot of stuff explained for you, but we can't give you the answer of whether you're in a controlled group or an affiliated service group. You have to go into the calculator already knowing that information. So if that's unclear, you're not sure, you'll want to talk to someone that can get that answer for you. And that may involve pulling in an attorney or a tax advisor that knows the tax code on section 414 of the tax code that addresses that and can walk you through the finer points and make a determination. Okay, that's Affordable Care Act reporting. I know that's top of mind for pretty much all employers. If you've done all the work to review everything, awesome. Make sure you checked that XML file too, and that you're keeping copies of everything for at least 6 years. Next up, mental health parity. So we've had this around for a long time. In September, we got a final rule updating some things. A lot of it is effective in 2025. So we're already subject to quite a bit of this, and we want to go through some of the finer points. So mental health parity in general says a plan that provides any kind of mental health and or substance use disorder benefits. I'm going to call those MHSUD. Must ensure those benefits operate in parity with medical surgical benefits in each of the 6 classifications that you see on the right. We have to analyze things like our financial requirements. So what kind of a deductible, what kind of a copay, what kind of a coinsurance can we apply to MHSUD care in each of the 6 classifications based on the deductible or coinsurance or copay that applies more than half the time to at least 2/3 medical surgical benefits in that classification. If it applies that much on the medical surgical side, that's the number we can apply to mental health and substance use disorder benefits in that classification too. Same thing with visit limits. If you try to impose a number of limit, a limit on the number of visits, then we have to evaluate, do we apply that more than half the time to at least 2/3 of medical surgical benefits in that classification? If we do apply such a visit limit, then we can apply it to MHSUD in that classification too. So we've had that rule for quite a while. It's not hard to get to the math to do all that well, but you do have to dig into claims. You can't just look at a plan design and tell if you're compliant. You might have to dig into claims and figure out, well, what applies more than half the time to at least 2/3 of care in that classification? So it can involve some math, digging into claims. What's much harder to get done is evaluating our non-quantitative treatment limitations, or what the government calls NQTLs. These are things like deciding who should be a network and is our network adequate when we are looking for MHSUD care. How do we determine medical necessity for MHSUD conditions and treatments? How are we determining whether prior authorization is required to seek treatment for a mental health or substance use disorder condition? All these kind of non-numeric things that go into determining what should we cover and how much and who should be in the network. All those things are NQTLs and a lot more. There's so much that goes into listing out all the NQTLs that can apply to your plan. And we have to make sure they are operating in parity as well. So they cannot be more restrictive than the predominant NQTL that applies to substantially all medical surgical benefits in the same classification. As you can imagine, that's a little tougher assignment to get done. So it tends to be a pretty heavy lift. It requires a pretty comprehensive analysis, and that tends to be something that only the carrier or the TPA has the data, in the backup support of the history and how the NQTL was developed and how they determine who should be in network. All those things are generated and originate from the carrier or the TPA. So they tend to be the only entity that can really realistically get this done, do this deep dive analysis. What they found is, since the CAA of 21 came out and said, we really need to have this analysis in every employer's hand across the country by February of 2021. What they have found each year since is it's largely still not in employers' hands. And to the extent that they can't get an NQTL analysis or a QTL analysis from a plan, they have to go digging to figure out, well, what NQTLs are you applying to conditions that I'm investigating as a government agency? And so they issued some final rules in September to say these NQTL analyses aren't getting done, and we really need them to get done. And here is some better instructions on what we are looking for. We have 6 required elements. I'm not going to go into those. That's something that people that do an analysis need to go into. But they do need to explain everything that went into designing and implementing every single MHSUD and QTL in each of the 6 classifications. And so they really want these 6 elements, every MHSUD and QTL, in each of the 6 classifications. So if you're doing the math for one NQTL that applies to a specific condition or service, that's 6 times 6 is 36. That's one analysis, and the plan probably has 100 NQTLs at the end of the day. So as you can imagine, this is going to be a pretty big analysis, pretty big report, very in-depth, and we have to explain everything that went into designing and implementing and deciding how many people does it take to staff a prior auth department or a network composition creation team to reach out to providers and see if they'll join the network. What's it going to take? All that stuff has to get explained and justified in this analysis. And not only do we have to prove it's operating in parity in writing, we have to crunch the numbers behind the scenes to back it up. We got to look at the claims, look at how often people are trying to go in network and can't, or go in network and can't get treatment covered, or run into barriers or red tape. All those kinds of things have to be evaluated and see, do the numbers back up that we operate in parity? This is a pretty heavy lift. This is a lot of work. And it used to be that when the government came knocking, asking for a part of our analysis, we could have 30 days to respond. Now they have said you can have 30 days to respond to the request from an individual or their MHSUD provider, but when the government comes knocking, you have 10 business days to respond and give this information. So now we're in a little bit of more of a bind than before, where we probably can't be waiting any longer. We need to have this analysis in hand and ready for requests that come along from individuals or their providers, as well as the government. And down at the bottom here, we do discuss that a plan fiduciary is going to have to start certifying that they've engaged a prudent process to select a qualified person or entity to run these required analyses for both QTLs and NQTLs. Have it reviewed with that plan fiduciary and that they are going to hold the entity accountable, because chances are the analysis is going to uncover some gaps, some areas that they're not operating in parity and need some correction. And so they're going to have some assurances from the carrier or TPA that that is being addressed. What the primary objectives of this final rule really are about is they want to see in-network access to MHSUD care rapidly improve. They want to see less barriers, less red tape to getting things covered, much less prior authorization required and concurrent review requirements. They just want to see a lot of the restrictions and barriers to MHSUD care to go away. And so they want to implement corrective actions when you identify a deficiency, implement correction actions to make it better, get things operating back in parity with medical surgical. And every plan fiduciary needs to have their own plan's full analysis. A statewide book analysis from your carrier or TPA is not sufficient. This is supposed to be specific to your plan. We're waiting on guidance of what that fiduciary certification looks like. So more to come on that. But right now, the idea is the fiduciary should have one on hand in their possession and have had a chance to review it with the person or entity that is running all their NQTLs on MHSUD benefits, so that they understand where they're at today and what improvements are being made to close any gaps. There is some litigation over quite a few aspects of this, in particular, the 2026 provisions that we didn't really talk about. And all of the 2026 provisions are also under a president's regulatory freeze to do a review and see if he wants to open those back up for some more public comment and possibly revisit the 2026 requirements. So we're not getting into those things today since they're under litigation and a review to possibly be changed. But for 2025, this is where we're at. We really want to have an analysis in hand so that the fiduciary of the plan can certify they engaged a prudent process to have a proper analysis run by somebody qualified to do it. Want to be able to respond timely to a request from a person or their MHSUD provider for the restrictions that are going to apply to care they would like to get. And we want to be able to respond timely to a government request. So our options might be secure data from our carrier or TPA and outsource the analysis to a third party. The costs we've seen out there are upwards of $10,000. So when you're thinking about having to run this every year and crunch numbers every year and show that we're making improvements every year, that's a real cost. That is something to be thinking about and seeing if you want to budget for. Ideally, we would get to a place where the carriers or TPAs provide the analysis, but so far the government has been telling Congress in an annual report all the analyses they see so far from carriers and TPAs are insufficient. They're not meeting the mark. They're hoping the final rule with the clarification of what they're looking for in the analysis will help get them to be more compliant, more aligned with what the government is looking for, so that when they come knocking and asking for that, they're not having to go back and forth on, well, it's missing almost everything I need. Hopefully we can get to a place where carriers and TPAs will be able to provide that assistance and do that analysis. The cost that we've seen out there for carriers and TPAs to provide it directly seems to be, in some situations at least, quite a bit less than outsourcing to a third party. And so hopefully that becomes a new normal that we can move toward, because if you think about it, the carrier or the TPA is really in charge of designing and implementing every NQTL that applies to MHSUD care. So from deciding what's medically necessary and what requires prior auth, and staffing up a prior auth department to review those things, to deciding who should be in network and what's appropriate to pay them, all those kinds of things are at the carrier and TPA level, not necessarily the employer level. So it makes sense for them to be the ones that have all the data and the history behind designing and implementing each MHSUD and QTL, and should probably do the analysis. As a stair stepping to this, because it is such a heavy lift to evaluate all the NQTLs that apply to MH-Sud care in our plan, it might be good to at least see if the carrier TPA that won't do the full analysis for all our MH-Sud NQTLs, will they do it for the ones that cause the most investigations and complaints and problems? The ones that generate the most requests. And for those would be a focus on adequate network access. It would be autism coverage, eating disorder coverage, and medication-assisted treatment for opioid use disorder. Those are the things that are generating almost all of the requests for, I need to see the NQTLs that apply to care I am looking to get, or that somebody submitted a complaint. And so the government is coming along and saying, I need to see all the NQTLs that apply to getting this care that somebody has complained about. If we could get some of that cleaned up, we would be able to timely respond to requests for the things people are asking about the most. And we would have some assurances that maybe we are getting to a place where people don't have to ask anymore because we have a robust network so people can get in-network access to care, and we're getting things approved and not putting red tape and barriers in their way near as often as we used to. And so the requests for information slow down, the complaints to the government slow down, and maybe we can have the plan operating in parity in the very near future. Doing nothing seems to be maybe an unsafe option these days. It used to be we tried to reach out to a carrier TPA and they would tell us, we'll do your analysis if the government comes and asks for one, because we had 30 days to get it done. But if the government isn't asking for yours, I've got other people that have the government asking for theirs. I can't do yours unless the government comes and asks. Well, now we're in a little different space. We have 10 business days to respond to their request, the government request. We have 30 days to respond to an individual or provider request, and we have a fiduciary certification requirement. So doing nothing or just reaching out and asking if I can have it and getting an answer of no, I'll give it to you if, doesn't seem as reliable a solution anymore. We probably want to take it to the next step. So for 2025, we're definitely encouraging employers to think about ways to bridge that gap. It may be a stair step from right to left here, but we'd definitely like to see parity come into focus. Next up, we did have a proposed rule in January to beef up the cyber requirements of the security rule. This affects employers as plan sponsors and their business associates. Don't want to go too in-depth on this because a proposed rule from January will be under regulatory review with the new administration, but there is a heightened emphasis on cyber breaches are becoming pretty significant, and they're in the news a lot. And maybe it's time for beefing up the security around our health plan and the ePHI we have access to, and making sure we're doing all the diligence we can to protect people's ePHI. So from an employer perspective, we're focused on employer sponsoring a level-funded or self-funded medical, dental, or vision plan, a health FSA, a limited purpose FSA, or an HRA, including an ICHRA. These are all the kinds of plans where the employer has access to ePHI. If an employer has a fully insured plan, they usually don't have access to PHI unless they have a claims data feed, feeding maybe some analytics software, and or some large claim detail reports. Maybe they get pulled into some appeal decisions, something like that. So to the extent the employer is fully insured but does get some ePHI, this applies to them too. And the security rule requirements are pretty straightforward. You want to have a security official, typically not the same person as your privacy official. This is somebody that knows cybersecurity. And so they're going to be very in-depth on the technology side. The privacy official doesn't necessarily have to be. They are going to conduct a security risk assessment to identify what ePHI could we have access to if we should choose to access it, and what vulnerabilities exist. in having that access and anything that we should download or use or disclose, what vulnerabilities exist that I need to protect. And then you develop policies and procedures around building protections and then training people to make sure, hey, these are the policies, the protocols that we have to follow, the technology we have to use to make sure ePHI does not become compromised. We need to monitor business associates and promptly follow HIPAA's breach notification rules. So those are the basics. And what we have found, we do a lot of compliance checkups, and we find often that employers that have any kind of level funded, self-funded plan, even something as simple as a health FSA or an HRA, may not understand or have done all of the formalities of what the HIPAA privacy and security rules require. That security risk assessment might not have been done. We might not have detailed policies and procedures, might not have a breach notification rule. It is worth considering for 2025 in this breach environment that we have, whether to go revisit those tasks and maybe brush up on those and see what we can put together. There are vendors in this space that can help. And it tends to be a one and done thing. So once you've gone through the formalities of what HIPAA wants you to analyze and put controls and policies over, that tends to be good for quite a long time until you significantly change the operating environment. Maybe you go from fully insured with an FSA, so you did all this with respect to your FSA. Someday you move to self-funded and you still have the FSA. Well, when you move to self-funded on your medical plan, that's the time to revisit the whole analysis start to finish and maybe pay that third-party solution to help you go through everything again. But if you don't have such a significant change in your operating environment, it tends to be a one and done thing. It doesn't have to be scary, it just has to get prioritized and not backburnered too bad. Enhance where you can. We had these proposed cyber updates to the security rule. We don't know where those will go. With a regulatory freeze and a review, we don't know if any of those will come to fruition, but there were some ideas proposed in there that maybe you could consider. They proposed we should encrypt ePHI no matter what, whether it's stored on a local drive, should be on an encrypted drive. Whether it is being transmitted from our server to somebody else outside our server, encryption should be used for that communication. So maybe we can get to a place where ePHI is encrypted no matter what. Maybe we can figure out ways to isolate ePHI so that it's always in a safeguarded system that you have to access. You have to go through multi-factor authentication. It's logging all the activity. Maybe we can get to a place where that happens instead of, oh yeah, we have ePHI and it sits in someone's email for 10 years and anybody that hacks their email can see it. That's not a great operating environment. Maybe we want to beef that protection up a little bit to say that's not a protocol we can follow anymore. So those are the kinds of things that employers can be thinking about. If we haven't complied with the basics, let's think ahead to what else can we do. We're going to get the basics covered and maybe enhance some things because it's time. Cyber is on the rise. It's significant. We want to be protective. And then, of course, watch for the cyber updates. We have the proposed rule. We'll see where it goes. They may change it quite significantly. Time will tell. But eventually, I expect some cyber updates to come in some form or fashion. So we'll just keep an eye out for that. Next up, we do have RxDC reporting coming up. This is due annually by June 1. This will be the fourth round that we've done. So I'm sure this won't be new to anyone on the call, but to the extent your carrier or TPA will do this reporting for you by June 1, they're usually going to reach out to you with a couple of questions. And they'll probably reach out to you in late February or sometime in March. So this is the time to bring it up. They're going to have a firm response deadline that you need to respond by in order for them to do the entire reporting for you. If you don't respond to their survey by the firm deadline, there might be parts you end up having to report on your own. So really important to look out for that, know what their firm deadline is, and keep that on target. What they're going to be asking for, I've highlighted in red. They really just need to know how much did the employer pay versus how much did people pay for calendar year 2024 medical and RX coverage. And if you're fully insured, that's an easy number to go grab. They don't know how much the employer is paying versus people are paying. And we do have COBRA people in the mix too. But for calendar year 2024, regardless of what our plan year is, this is what they're concerned with. If you're self-funded, they need a premium equivalent. So to the extent you had a self-funded arrangement, you're going to be looking at actual fixed costs and actual claims. You can use either incurred claims or paid claims. You're going to pick one and stick with it each and every year, because what we're looking for as we do this reporting each year is trends. And so we want to be using the same underlying data every year. So either pick incurred in the calendar year or pick paid in the calendar year. Stick with that each year. Add that the fixed costs for that calendar year. Take out your stop loss rebates and take out your RX rebates that are retained by the plan, and you'll have your numbers. So that hopefully will help you with responding to those survey questionnaires by their firm deadlines. Of course, we have a new Congress, new administration. Do want to spend a minute just kind of talking about the regulatory freeze I mentioned. Anything that's not effective from a regulatory perspective is going to be under review for 60 days. So we're about 30 days into that now. The 2026 stuff related to that September MAPIA final rule will be under review. That proposed cyber HIPAA update from January will be under review. There may be some other things, but those are the two big ones that we expect some change on. There was an executive order withdrawing the indemnity notice requirement. There's an executive order declaring two genders that cannot be changed. So from a federal law and regulation perspective, they intend to change the interpretations of and enforcement actions against plans and employers related to treatment of gender dysphoria. We don't know how far they can go because Title VII civil rights law was updated by Bostock. The Supreme Court in the Bostock decision did say Title VII civil rights discrimination on the basis of sex does include discrimination based on sexual orientation or gender identity. And since Title VII covers all aspects of employment, including benefits, there is a risk if you want to impose a limitation or restriction or an exclusion on gender dysphoria treatment, you want to have counsel on your side. We have a case from last year, actually from a couple years ago. It was appealed last year to the 11th Circuit, and they ruled in favor of the plaintiff that filed a complaint against an employer and their health plan that had a restriction on gender dysphoria treatment, and they won. The employer lost that on appeal as well. So under Title VII. So even if rules change under some of these other things like the Mental Health Parity and Addiction Equity Act on whether gender dysphoria treatment must be considered with respect to mental health parity, Title VII civil rights are going to be a primary concern, and you'll want counsel advising you there. Looking ahead, we think this stated goal of removing 10 regulations for every new one they want to introduce and having the total sum cost of all the new regulations and the 10 that they repeal for each one come up to a total cost for the year of significantly less than zero means their hands are going to be tied on what they can really write rules about. And that proposed HIPAA rule is a good example of something that asked for some pretty robust enhancements and backup procedures and annual auditing. It had some hefty price tags attached to it. In order for something like that to come along, it's got to remove 10 pretty expensive rules. So that's the kind of gist that we're looking at. What we think is more likely to happen in the near future is maybe Congress in bipartisan effort looking to relieve HSAs and give some flexibility for direct primary care, telemedicine, some of the things that tend to be popular on a bipartisan basis. But for right now, executive orders just tend to indicate intent. We're going to wait to see some rule changes or some law changes to see where we go from there. We got increased DOL penalties in January, so just highlighting those here for you. And the key takeaways for today, just have a plan for your ACA reporting. Just understand which forms you're supposed to do by when, or do you want to take advantage of the new relief to only provide them to people on request? If so, make sure you have a disclaimer on your public website by March 3rd that gives you that latitude to be able to say, I only give them to people that ask. Keep everything on file for 6 years, including that XML file. Look through that XML file for accuracy. Keep all the forms in the XML file on file for 6 years, and you should be in good shape with your ACA reporting. Start requesting your MAPIA QTL and NQTL analysis. See what kind of a response you're getting these days. These carriers and TPAs are starting to beef up the data they'll provide, even if they aren't yet beefing up the analysis being provided. So it may be that they're stair-stepping toward some compliance measures. Consider some proposed cyber updates to the HIPAA security rule. If you haven't engaged in the formal HIPAA process with respect to your self-funded plan, level-funded plan, FSA, HRA, you name it, consider getting those basics fixed and having the framework built so that the protections are there and they're formally addressed. People are formally trained on the policies, procedures, technology that you've implemented, and consider the ways that you can enhance some of the security protocols to keep up with cyber and what's going on in that space these days. Look ahead to the RxDC reporting. Make sure you know when your carrier or TPA is going to reach out to you and what their firm deadline is. Maybe start gathering the answers to their survey questions now so that you can respond to those on time. And just be on the lookout for where the new Congress and new administration are going to take us. Executive orders don't move much right now. They indicate intent. We're going to be looking for those rules and those laws to see where do we go from here.
Great. Thanks so much, Casey. If anyone does have a question for Casey right now, you can go ahead and type it into the question and answer feature on the webinar. We haven't had any come in yet, but if you do want to type anything in, please go ahead right now. Otherwise, if you think of something after the webinar, you can certainly reach out to us and we will get you the answer you're looking for. A couple housekeeping items before we wrap up today. If we could go to the next slide, Casey, we do have some Sherman HCRI credits. You can jot down those credits for attending the webinar today. And again, this webinar has been recorded and we'll be sending out recording and the slides before the end of the week if you did want to go back and review any of the information Casey provided today. And one last thing, if you could hang on for a minute or two after we end the webinar, there will be a short survey. We'd love to hear what you thought about today's webinar and give us some ideas for future webinars or items that we can include in these. I still don't see any questions that have come through. So with that, we will wrap up today. Thanks again, Casey, and thanks to everyone who has attended. We hope you have a lovely day.
Thank you, everybody.